and the fibula ligament. Her case, right? Her case, 2 millimeter. So the ligament is smaller than 2 millimeters. Right, okay. Mine is 4. So the ligament is about 3. So it's okay to observe. But, okay, let's repeat again. LCL, right? Find the LCL. Heel walking and move forward slightly. Bicep femoris. Okay. Yes. And popliteus tendons. Find the popliteus tendons and start from the fibular head. It's popliteal fibular ligament. This is very, very important ligament. But if you invite me next time, I will show you. Thank you. No, I was kidding. The probe is not very good. Okay, try this. Try these 3 first. 1, 2, 3. And the meniscus. 4, 5. Fibula. Fibula. Okay. No. 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 Don't cry. We don't need the fibula. I need the fibula here. Yeah. Fibula is correlated to the strength of calf muscle. Strong calf muscle often has a fibula. Okay, suckers. No, twice. Next one. Or you can invite the girl. She has 2 millimeters fibula. No. The LCL ligament, right? Popliteus. This is dark. Why this is dark? Because when I was a student, we don't really know the orientation of the probe. We only look at the border. And someone suggests, no, we have to have a stand-up procedure. The orientation of the probe, the distal sign has to point to the fibular head directly. This probe is 5 centimeter probe. So you can see the femoral condyle, sulcus, and the fibular head in one imaging. Okay? The probe you use is less than 4. Not possible. So you have to move the probe to the fibular head. So they use very good machine, but the skill is not good as you. So the pictures looks like this. Dark. But you know the LCL is bright. The popliteus tendon is dark. If you look at this imaging, you find there is a tiny artery here. Tiny artery. And if we have time, we can try arcuate ligament right above the artery. Some people have very strong arcuate ligament, and ligament press the artery, cause symptoms. The reason why we need to address this, because around 2000, the year of 2000, my supervisor suggests raised an argument. He suggests that physical therapy or sports medicine personnel need to look at, or specialists need to look at the posterior lateral corner instability or disorder. And he asked me to check the student's response. And the student's response was very poor. No one listened to him. That's normal, right? When we talk to the student do not give up, so it's normal. But now, it is very important topic. The important top structures in the posterior lateral corner include LCL, popliteus, popliteofibular ligament, and arcuate ligament, and also PCL. So, we need to use ultrasound to check these one by one. Find the fibular head, move anteriorly and use the heel walking scale. You find the bicep femoris tendon, very thick, very strong, very thick, very strong. If you move the probe upwards continually, you will find the iliotibial band. Iliotibial band is very easy to find if you are interested. This is an example of iliotibial band freezing syndrome. There are a lot of fluid surrounding the band. Okay. And the triangle shape is not perfect triangle shape anymore. There is a gap inside. And the gap can be observed more clearly when you're doing the internal rotation. Yeah. Thank you. Okay, the popliteofibular ligament. I will try later. But I'm not guaranteed. But fibular ligament. I think some of them in this room some of us in this room does not have a fibula, right? But you got a fibula, 4 millimeters. Yes. But we will try with the machine. Then we look at the arcuate ligament more. Basically, it's not difficult at all, easy. But you don't believe me because I have been seeing easy for the old days, but you feel frustrated. Find the LCL, easy, right? Please, suckers, popliteus. I told you, move forward and use heel walking scale. Find the bicep femoris. And move forward, find the iliotibial band. Okay. Move downwards. You can observe the arcuate ligament. Arcuate ligament basically are very invisible. So we use the artery. to help us to identify the accurate ligament. As long we noticed yesterday in the shoulder joint, some participants, their suprascapular artery does not show pumping in the ultrasound, right? But we can try, but not guaranteed. Okay, then we are going to close. We are going to introduce some structures. Then we are going to close our class today. There is a, yes. In Taiwan, okay, we begin from the medial side or lateral side. Either way is okay. If you begin from the medial side, if you begin from medial side, at the knee level, medial condyle, okay, the level corresponding to the level of medial condyle, you find a huge mass, head of medial gastrocnemius, and three spots. This is very easy to find. Transverse view. This is very easy to find. 3 spots, a dark point, a bright point, another dark point. Semi-membranes, semi-tendinous, okay, and the sartorius, SGS. Easy. Because this is very, very easy to find. If there is a fluid inside, ladies and gentlemen, Baker cyst. So, as long as you, but sometimes personally, if I check the medial collateral ligament, I will ask the patient to prone, then same level, right? Because we found the medial collateral ligament start with the medial condyle. When they get prone, same level, look at it behind. Yes. And if you start the back knee from the LCL, it's the same. From the lateral condyle, and ask the patient to prone and check the level. So 4 structures. The easy one, dark one. Dark is very easy to identify. So in order to see something dark, we need to reduce the dynamic range, right? So are you going to need the help from Mahito staff, or you want to do the job by your own selves? No, just press the button, reduce the dynamic range to 90. Let them do the job. If they do not do the job very correctly, we will shout, "I told you." Okay. Reduce the dynamic range to 90. I told you twice, 3 times. Okay, good. And find something dark. Okay, above the medial femoral condyle. Okay, and 2 dark membranes, sartorius, 1 bright, tendinous, because it's tendinous, tendinous, bright. Okay, fluid between semi-membranes, medial gastrocnemius, may indicate bursitis. Some people call Baker cyst. Okay. Good. You are totally confused. Good. Yeah, that's my job. this student has very poor skill. This student has very poor skill. Medial Geytroninius, head of medial Geytroninius, and there is a dark area here. Oh, there are fluid in here. No, where is the cortex line of the medial femoral condyle? No, so don't tell me you find something interesting. Give me an image with better quality. This is an example of Baker system. Or medial Geytroninius semimembranous bursitis. But if this cyst does not cause problems in deep squat, usually physicians does not do anything to this. They don't even use needle to inspirate the fluid out, because the fluid will go back, will come back again, and very quickly. Okay, if the patient is suffered from a big cyst, a big Baker cyst, some medical doctor may remove the cyst by surgical. Okay. Then, if we are going to, then we move to the center, medial. Then we move to the center of the back knee. There are one thing pumping, deep. So, in order to see something pumping, we need to reduce the persistence to 3. Because we used 7 or 5 before. Because the artery is pumping, right? But the pumping, the image of pumping are averaged by the persistence function. So we did not easily see the pumping of the artery because we increased the persistence. The reason for us to increase the persistence because we want to reduce the noise. So reduce the persistence to 3. 3 means one image present 0.1 seconds echoes response. Do that. Okay. Reduce dynamic range to 90. Reduce the persistence to 3. Okay, they are totally confused. Good. So we can keep shouting. Yeah, good. Okay. 3 things between the middle head, between the head of medial Geytroninius, head of lateral Geytroninius. There are 3 structures: pumping, vein, tibial nerve. Yes. Okay. Then moving. Oh, that's it. Okay, sorry. Right, I think I lost one slide. If you move the probe to the behind the lateral femoral condyle, you will see a bright spot Oh, very similar to this one. Yes. And behind the lateral femoral condyle. Okay. This is a panoramic imaging. So basically, the image is about this size. This size. So this imaging was combined by 2 or 3 imaging. Okay. Panoramic view. 1, 2, 3, 4, 5. Okay. So this imaging includes lateral femoral condyle, and this is the common peroneal nerve. Common peroneal nerve. Okay. So 1, 2, 3, 4. 1, 2, 3, 4. Can you see the honeycomb profile in the common peroneal nerve? Okay. Then the nerve will divide to superficial peroneal nerve and deep peripheral nerve that we are going to check and observe tomorrow. Okay, that's it. So I'm going to demonstrate again. So then I will let you practice from 15 past 4, and we are going to finish. Ask you to stop to practice before 5 o'clock, so everyone can pack and go home. Cool. Any questions? Any questions? No? Good. So the lady, she very good in kicking box. Yeah. Can you help me? The lady very good in kicking box. She right. Okay. Because I know this machine, the best range is about 1 to 3 centimeters. So I'm going to increase my depth and put the structure that I want to see in the between the zone zone. LCL, popliteus, no problem, right? Cool. Then move backwards. Okay. Okay. No one was listening to me. Okay, thank you. Right. This is the cross-sectional area of the IT band, right? Okay. Become smaller, right? Narrow, become ovary. Flat, ovary, flat, ovary. See that? Okay, cool. APMR. Really, yeah. And another, modify over test. Sorry, I need to do it again. Chill. Thank you. Yeah, thank you. Okay, good, better. Because the gel is nerve, so I need to put the IT band in the bed in a good focal zone. Okay. Start to stretch. Become narrow. Ovary. There are two bands, right? Okay. If you are not very good, I can move the probe slightly higher. Okay. That's the cross-sectional area of IT band. It's wider now because the level is higher. So you found that the anterior, which one change most? The tail or the head? The head is the left side. The tail is the right side. Okay. Can you tell me the head change more, or the head change more, or the tail change more? Which one? Tail. Tail is the tibia check. Two bundles, yes. But I didn't differentiate the two bundles in my study. I just used one. But now, sorry. Okay. Can people help? Yeah. You hold the probe, of course. Okay. So I didn't differentiate the iliac patella band, iliac patella check, and the iliac patella band and the iliac tibia check. I didn't differentiate. I only compare the total width of the band is reduced during the stretching. Okay. That's it in my personal study. Yeah. That saved me for another 3 years to survive.